Wesam Kurdi, she's a professor in Al Faisal University, head section of maternal fetal medicine, Department of Obstetric and Gynecology, King Faisal Specialist Hospital and Research Center. Professor Wesam Kurdi.
Assalamu alaikum wa rahmatullah. Good morning, ladies and gentlemen. And it's always my pleasure to come to SHMS meetings and to be part of this prestigious group. So I'm going to be talking about hypertension in pregnancy, updates on management. Do you have You will change? Okay. We know that hypertension remains one of the very important complications of pregnancy, and it's one of the leading causes of maternal mortality, where up to 20% of maternal deaths are actually related to hypertension during pregnancy. And it's a very important cause for ICU admission. And also don't forget the fetus, so it is also related to an increased risk of prenatal mortality as well. We classify hypertension in pregnancy into 4 categories. Pre-eclampsia, eclampsia, which is something related to the pregnancy itself. There is the chronic hypertension. There's chronic hypertension with superimposed preeclampsia, and there is gestational hypertension. And we'll go through some of these classifications. It's very, very important to know that the presence of hypertension during pregnancy is associated with a lot of pregnancy complications. So studies have actually shown that most of the pregnancy-related complications are increased with the presence of hypertension, increased risk of cesarean delivery, preterm delivery, superimposed preeclampsia, small for gestational age, NICU admission, and perinatal death. And the very important thing that we should always remember is the degree of the hypertension. So if the patient starts the pregnancy with high blood pressure in the severe hypertension range, then her pregnancy complications are much, much increased. So if you look into this slide, we'll see that superimposed preeclampsia will be around 50% if she has severe hypertension versus only 10 to 25% if she has mild to moderate hypertension. And this is where the role of you all actually comes into the picture, where the patient needs to be really well controlled before she comes into the pregnancy in order to improve her pregnancy outcome. And don't forget that we don't only deal with the mother in pregnancy, but we also deal with the fetus. So we need to know the effects of the high blood pressure on the fetus and the effects of the medications as well on the fetus. Can you hear me well? Because, yeah, okay, it's coming as an echo in my ears. So studies have shown that treated and untreated hypertension is actually associated with some effects on the fetus. So there's an increased risk of all major congenital abnormalities, and specifically there's an increased risk of cardiac congenital abnormalities in hypertensive patients. So this is something very, very important that we have to keep in mind. And this is treated and untreated. So the hypertension itself actually has a problem related. So why do we treat hypertension? Obviously, you're the experts in the treatment of hypertension. We treat it to prevent long-term end organ damage. Can you still hear me? Yeah? And to prevent the acute effect of the high blood pressure in relation to like strokes or bleeding in the brain and so on. So the long-term effect is actually not there in pregnancy, because the pregnancy is a short duration anyhow in the woman's life, but the effect of the acute high blood pressure is something that we should worry about. And that's why we actually, when we taper our management, this is what we look at. Is there any effects on the long term, or is there like an acute effect because of the severe high blood pressure that we are dealing with? And therefore, if we are dealing with mild to moderate hypertension, so maybe we are not really very worried about the effect of the severe high blood pressure that might have like an acute insult on the mother. And therefore, in these cases, we really have to weigh the benefits of the treatment versus the effect that we might have on the fetus. And remember that during pregnancy, there's a very, very important concept that happens in the physiology, which is the physiological drop in the blood pressure. So we actually utilize that physiological drop, and maybe we are able to even stop the medications in the beginning of pregnancy. But remember that you can only stop medications in patients who are in the mild range, they do not have end organ damage, and usually if they are only on one medication. So benefit from the physiological drop in the first part of pregnancy, and usually till we reach the third trimester. Usually we know in our practice by the stage that she is like 28 to 30 weeks, the blood pressure will start to rise again, and at that stage you might need to reinitiate your antihypertensive medications. But remember, this does not include patients who are more complicated, or patients who have other comorbidities, or patients who have already end organ damage. These are patients that need to continue on the antihypertensive medications. So, what do we do with the blood pressure in pregnancy? Do we need to really be very strict on the blood pressure control, or we can be a bit more liberal? Because we just mentioned that the high blood pressure that is important for the end organ damage is the prolonged high blood pressure, and pregnancy is not a prolonged duration, and because we want to avoid the problems on the fetus. So there are studies that actually looked into how tight we need to be. And these studies have shown that there is really not much difference in the outcome. I hope you can see these numbers. I'm not sure actually if you can or not. But anyhow, there is no much effect on the fetus from the tight versus the less tight control. So there is no like negative effect on from the medications. But the important thing is that if you have less tight control, you are more likely to have severe high blood pressure. And if you have severe high blood pressure, you are more likely to need to admit the patient to the hospital. Maybe at that stage you need to use more expensive medication. So at the end of the day, there is really no much benefit from the less tight control. Yeah, cost benefit from the less tight control. So maybe it's better to actually have a better control to avoid the risk of severe hypertension that might become like worrisome for you and for the patient herself, and maybe increase risk of complications. Obviously, if we have severe high blood pressure, there is no, we cannot give away the medications, and we really have to control the blood pressure quite well. And again, it goes with the same things that has been mentioned over the last couple of days. If you have end organ damage, then your aim is to be a lower blood pressure control. Our medications, I'm sure nobody has heard of methyl dopa so far in this meeting, because I think it's only us obstetricians who continue to use methyl dopa. It's our first-line medication for hypertension in pregnancy, because we have been using it for many, many years, and it's reasonable control for patients who are in the mild range of high blood pressure. Obviously, don't forget the side effects of the methyl dopa with respect to headache, with respect to depression, and so on. But it's a good medication. The other medication that we are more and more using these days is the alpha-beta blockers, like labetalol. It's a very good medication. The problem with it that it is more likely to be associated with a small for gestational age, and therefore usually if you are going to use it, it's better to actually use it for the hypertension that develops in pregnancy rather than using it for the chronic hypertension, because there are some recent studies that have actually shown that there is an increased risk of complications or fetal abnormalities associated with the use of beta blockers in the first trimester of pregnancy, including cardiovascular abnormalities, including facial cliffs, and the neural tube defects. So if we can avoid using the beta blockers in the first trimester, it's better for the patient. So our good old friend is methyl dopa, unless the pregnancy develops hypertension later on, then you can use the labetalol. Other antihypertensive medications, ACE inhibitors, hydralazine, diuretics, if the patient needs it for other indications, are quite safe. The only ones that we don't actually like in pregnancy are the ACE inhibitors and the ARBs, because they are associated with premature closure of the ductus, they're associated with renal problems, and there are some recent studies that shows that they might actually be associated with cardiac defects if used in the first trimester. So these are medications that we avoid in pregnancy and even during breastfeeding. The blood pressure that develops in pregnancy, like we mentioned before, are like two categories, are pregnancy-induced hypertension or gestational hypertension or preeclampsia. The difference between both, I'm going to be talking about in the coming slide. So when we deal with gestational hypertension, which is basically just pure hypertension that develops for the first time during pregnancy and after 20 weeks of gestation, these cases are usually managed by obstetricians unless there's very difficulty in controlling of the high blood pressure. And usually when they come to the severe range, this is the stage where we actually need to give them antihypertensive medications. If they are more into the mild or moderate range, we might not need to give them antihypertensive medications to avoid the effects on the fetus. Although we know in clinical practice that if it develops quite early in pregnancy, if you give them antihypertensive medication, it actually allows you to prolong the pregnancy more and therefore to reduce the risk of the severe hypertension that might develop. While preeclampsia is the nightmare of any obstetrician because of its associated complications, because it's not only high blood pressure, it actually has effects on all other organs of the body, and therefore it's very, very important to diagnose preeclampsia, which is blood pressure with proteinuria, although we know now that we do not need to have proteinuria to diagnose preeclampsia. We can have only high blood pressure if we have other features of severe disease. So now we actually call it hypertension, preeclampsia with features of severe disease or preeclampsia with no features of severe disease. So the features of severe disease will include renal abnormalities, liver abnormalities, thrombocytopenia, pulmonary edema, or a brain edema and convulsions. So if we have any of these features in addition to the high blood pressure, even in the absence of proteinuria, this is still considered preeclampsia and should be treated as preeclampsia. So it's very, very important to know what are the risk factors for preeclampsia, because again, these are patients that might be seen by their general practitioners. They could be seen by an intensivist and so on before pregnancy. So if you know that there are pre-existing factors that might increase her risk of preeclampsia, these are the patients that will need to be advised about how to reduce their blood pressure effect, maybe to use medications that might reduce the risk of developing preeclampsia, and so on. And they need to be directed into tertiary care centers or maternal fetal medicine subspecialists to be taking care of them. The management of preeclampsia is different than the management of gestational hypertension, because usually preeclampsia is a more severe disease. Usually these patients, the initial management has to be in the hospital till we actually know what stage of preeclampsia they have, if they have other effects that might pinpoint towards preeclampsia with severe features, because the management of preeclampsia is actually delivery. So whatever medications we give them to reduce the blood pressure is basically aiming at prolonging the pregnancy, which we can actually achieve at least like 15 days prolongation of the pregnancy, but there is no treatment. The treatment has to be delivery. But prolonging the pregnancy is extremely, extremely beneficial for the unborn baby, especially if we are dealing with an early onset preeclampsia, because between 24 to 28 weeks of gestation, even 1 day prolongation of pregnancy reduces the perinatal mortality by 3 to 5%. So this is extremely important, and that's why conservative management of preeclampsia has a place to play in patients with early onset preeclampsia in order to improve the fetal outcome, but this has to be done by a multidisciplinary team in tertiary care centers with adequate facilities to be taking care of a potentially extremely sick mother and a potentially extremely premature and sick baby as well. Which level of blood pressure we need to control? This is extremely, extremely important. And like what we mentioned before, severe high blood pressure needs to be treated. And there's a lot of studies that shows that stroke can happen even at blood pressure less than 160 over 110. So therefore, really our aim is don't let the pressure go beyond 150 over 100, and definitely treat the patients at that stage. Even if you're going to consider an earlier delivery, a treatment is actually beneficial. The medications are similar to ones that I've just spoken about, whether we're going to use them for like mild cases or for the severe cases. But obviously in the severe cases, we might need to give the IV option rather than the oral option. And studies, And studies have shown that whatever medication you are comfortable with, you can use. So you can use calcium channel blockers, you can use IV labetalol, you can use IV hydralazine, and there is no really much difference in the outcome. So just use whatever you are familiar or your center is familiar with, or what you have a protocol that you have developed for that medication. It's fine. It doesn't really, there's not much difference. Like I said, delivery is really the cornerstone for the management.
More. 5 minutes.
5 minutes, excellent. Delivery is the cornerstone for the management of preeclampsia. So if you have mild preeclampsia, we just deliver at 37 weeks. There's really no point continuing the pregnancy because we have already reached maturity, and continuing the pregnancy might increase the risk of severe hypertension, which we want to avoid. But if we are dealing with severe preeclampsia or preeclampsia with severe features, we don't go beyond 34 weeks. And like I said, we actually continue the pregnancy only for the sake of the fetus. So if I have severe preeclampsia remote from viability, and if I have preeclampsia at like 20, 21 weeks of gestation, there is really not even any point of continuing the pregnancy. And in these severe cases, we might even consider pregnancy termination. So timing of delivery, chronic hypertension on medications, usually by 38 weeks. Chronic hypertension, on no medications. On medication by 37 weeks, and preeclampsia with severe features by 34 weeks of gestation. Remember that in the postpartum period, in the first 24 hours, the blood pressure normally drops, especially if the patient, had some excessive blood loss, as she had cesarean section and whatever. But after that, usually the blood pressure increases again. So it's very, very important to make sure that you're controlling the blood pressure during that period. You put the patient back on her pre-pregnancy medications if she was on different medications. Try to avoid Aldomet, but labetalol or calcium channel blockers, hydralazine or whatever can be used, but not the ACE inhibitors because of if she's going to breastfeed. Counseling is very important. If she develops preeclampsia for the first time, then her risk of future complications might be high, and these patients are the ones that we need to find out whether this is actually for a secondary reason that we did not know about, so she needs to be evaluated, and she needs to be counseled about her recurrence risk, which might be as high as 40% if she had early onset preeclampsia during pregnancy. How can we do just a few slides about risk reduction? We spoke about, diet, we spoke about exercise, we spoke about rest, all these things. Exercise is quite important. The problem is that the continuity of exercise might not be there in pregnancy, and strenuous exercise might actually increase the blood pressure. So we don't definitely advise women for the first time in pregnancy to start exercise. If she's used to it, she can continue on it as long as she avoids falling and all these trauma to her pregnancy. Bed rest doesn't really help, and obviously you don't want to put your patients in bed rest in hospital if she is pregnant just because of the high blood pressure. Diet, salt restriction for the chronic hypertensives, but not for the preeclamptic. Some studies have shown that folic acid might reduce the blood pressure a bit, but what we know that calcium actually has an effect in reducing the risk of preeclampsia, but it's only effective in patients with previous low calcium intake. So if she has normal calcium intake, it's not going to be effective. Aspirin is a very, very important medication. It definitely has been proven to have an effect in reducing the risk of preeclampsia, and definitely it is more effective if used before 16 weeks of gestation. This is recent data, and it's very important data. So if you see the patients who are at increased risk, they have risk factors for preeclampsia, please advise them to start aspirin early in pregnancy before 16 weeks of gestation. And these are some of the risk factors that we spoke about earlier. And to prevent preeclampsia, you really need to treat small number of patients to actually have an effect with the use of aspirin. Some of the screening that we actually utilize, uterine artery Doppler. If you use uterine artery Doppler in the second trimester and it's abnormal, then the risk of that particular pregnancy having preeclampsia is increased by 13 folds. So it's a very good screening test. There are other screening tests that are coming up in the market, which is the angiogenic markers, which is the S-FLIT, probably you heard about it, and the PIGF. These are like new screening tests that are very important. They actually have a predictive value for the development of preeclampsia. That's one way of utilizing them. And the other way of utilizing them is actually if you are not sure whether this is preeclampsia or a deteriorating, renal disease, for example, the presence of high levels or high ratio of S-FLIT versus PIGF actually pinpoints more towards preeclampsia rather than deterioration of a chronic hypertension or SLE or whatever. We're going to have these tests very soon at King Faisal Specialist Hospital, and we will be offering them even for private to the public. So it's something promising for the future. I think this is just a few conclusions, that screening is important, prevention by using aspirin is important for preeclampsia, treatment to prevent acute high blood pressure is essential, and preeclampsia is always our nightmare, so we do not take it easy. Thank you.
Thank you, Professor Wesam Kurdi, for this nice comprehensive presentation and for sticking for the time. Thank you very much.
I think we'll leave the questions until the end of the session. Our next speaker is Dr. Adil Sinan, who's a consultant pediatrician, and he's a board member of the Saudi Hypertension Society. He will speak about neonatal hypertension guidelines. Dr. Adil, تفضل.
I am asking all our distinguished speaker to stick to the time and maybe less, because the time is very tight and we are lagging behind.
Okay. Assalamu alaikum. We try during these 20 minutes to over-highlight neonatal hypertension. How is it distinguished, peculiar from other ages? Actually, this session, pregnancy, neonatal period, and children, adolescents, and geriatric, and the rest of the conference for the adults. So let's see this 4 or 5% of this conference, 20 minutes, how it varies neonatal hypertension from others. Neonatal hypertension actually is rare, said to be about 0.7 to 2%, up to 3%, the incidence of it. But is it of our intention and awareness to focus in? Actually, it is under-recognized practically, not in the intention. If you ask any neonatologist, their concern and their importance is the hypotension rather than hypertension, which is much more common with sepsis. The advances in the practice of neonatal medicine led to increased awareness of hypertension in neonatal units. Neonates managed in neonatal ICU who are particularly at risk of hypertension and may need pharmacologic treatment. Definition, unfortunately, is not like in adult, based on complication in the outcome of hypertension. Actually, it is statistical value rather than outcome. Hypertension defined as systolic blood pressure in a unit which is more than 95, equal or more than 95th percentile for age and sex on 3 separate occasions, at least 2 minutes separated time, as we will see in a while. Clinically significant hypertension which needs treatment, which needed treatment, high blood pressure more than 95th percentile, and there is end organ with end organ involvement, or blood pressure more than 99th centile, or said to be in full-term babies more than 110 millimeter mercury, or hypertension emergency more than 130. Neonatal hypertension, the incidence, as we said, from different sources, as low as 0.2 or 0.6, 0.8, up to 2.6 to 3%. Cumulative data showed about 80% of babies with hypertension had an umbilical catheter inside that play role in our speculation about aortic or renal artery thrombosis are common causes. Renal vein thrombosis and structural kidney anomalies constitutes for next largest group. For that, usually pediatric nephrologists are of the primary manager of neonatal hypertension. Chronic lung disease, particularly when dexamethasone is used, systematic hypertension, dexamethasone is known to increase median systolic blood pressure up to 27 millimeter mercury and usually resolved within 2 weeks after cessation of medication. Blood pressure reading from an indwelling catheter, that is invasive radial or umbilical artery catheter, is the gold standard in neonatal ICUs, but the most common methodology of measurement of blood pressure is an automated oscillometric devices. Blood pressure protocol, that is measurement protocol, is really mandatory. Probably till now, most of the institutes around the world lacking this. What is there, blood pressure, is the instruments are there and the nurse will take it. No, there are a lot of recommendation doing blood pressure measurement, especially in neonatal period, a special task. Measurement recommendation about 1.5 hours after feeding or medical intervention. We will see more comments in that with the infant asleep or in a quiet state and lying prone or supine. To place an appropriate size cuff. This is so common, erroneous reason for false high blood pressure. In the right upper arm, preferable, and or lift the infant wrist undisturbed after cuff placement for 15 minutes. Actually, the awareness of these informations is really poor, even of the caregivers. Measure by a oscillometric device and do 3 successive blood pressure reading at 2 minutes intervals. Umbilical artery catheter in place has one been in place in the past. This history is important, and for several weeks the incidence of hypertension said to be up to 9% with umbilical artery catheter. Umbilical artery catheter are associated with increased incidence of renovascular hypertension, probably related to thrombus. This is the speculation of it. Improved catheters, of course, catheter from the manufacturer point of view as well, using of heparin decrease this incidence. Hypertension appears with equal frequency in high versus low catheter. This dilemma there in literature, if we use high catheter better than low or low better than high, it's no difference. Signs of hypertension, still a dilemma for all ages, even here. Most of it is non-specific, doesn't worth it to talk about. Irritability, difficult to link. Most of they are prone for irritability, for tachypnea, cyanosis, seizure, of course, benign versus pathologic types. Is not peculiar, that's for hypertension at all. difficult to say. It's not evidence-based, it's just our assumption, maybe. Mottling, fever, abdominal distension, or non-specific, difficult to accept without evidence, but may also congestive heart failure, failure to thrive, GI problems, and respiratory distress. Blood pressure in the extremities, of course, all we know that higher in legs than in arms. If it is in legs, less. That will raise the issue of coarctation of aorta, one of most common cause of heart malformation that causes hypertension in neonates. Birth weight, gestational age, and postnatal age in the infant, increasing birth weight, gestational age, values rise about 1 to 2 millimeter mercury per day during the first week of life, and then 1 to 2 millimeter mercury per week over next 6 hours. We will see more details in a while. Pain from an invasive procedure, crying, agitation, suctioning, this all intervention can cause transient increase of blood pressure for that. During the measurement, that's really an art, how and when to take it without these artifacts. Systolic blood pressure can 5 millimeter lower during sleep. Fluid overload, especially if the patient is not, if the neonate doesn't void, easy to have an iatrogenic increase in blood pressure. Maternal drug use, cocaine, heroin, can prolong the neonatal period as withdrawal syndrome. Bronchopulmonary dysplasia, chronic coronary disease, and intraventricular hemorrhage in infants, especially bronchopulmonary dysplasia and chronic coronary disease, said to be from 6 to 40, and we'll see in a while about 13 to 40, so it's up to 30, and it may occur after discharge. But I didn't see anything to highlight or to validate how long to be followed. And is it one of the tasks to be followed in high neonatal OPD follow-up? And is it really routinely to measure blood pressure for neonates in the follow-up who have bronchopulmonary dysplasia and chronic lung disease? That's to be answered by the literature in the future. Infants with intraventricular hemorrhage, about 3% of them have increased risk of hypertension. Risk factors, and that really a reason to follow up for blood pressure below 3 years, as all we know from 3 years and above, is recommended to take blood pressure for pediatric age in all routine attendance to the outpatient clinic. So chronic lung disease, respiratory distress syndrome, prematurity, extreme low birth weight, umbilical artery catheter placement history, maternal hypertension, antenatal steroids, acute renal failure, acute renal injury in postnatal period, treatment with indomethacin or associated with increased development of hypertension. Normal neonatal blood pressure in ICU varies with gestational age, clinical age, and post-conceptional age, correlation in gestation, and birth weight. Hence, it is difficult to define normal blood pressure with all these variables. On day one, systolic blood pressure and diastolic blood pressure correlate strongly with gestational age and birth weight. Blood pressure decrease within the first 3 hours of life, then spontaneously increase 0.2 millimeter per hour over the first 24 hours. And as we said, it's 1 to 2 millimeter per day, then after 1 to 2 weeks, 1 to 2 millimeter per week, up to 6 weeks. Primary determinants of blood pressure, post-conceptional age, refer to table we see in a while. Beyond 2 weeks of age, infants from 26 to 44, that is by Dayon. Fourth task, from 26 to 44 weeks, post-conceptional age, 95th to 99th centile to match with the definition of hypertension and for management. The upper one is the 95th centile. This is a modified table, actually. It's a long table. I used one for the purpose of the presentation. It's by Dion in 2012, North America. As we see, from 26-weeker gestational age up to 44-weeker. Here is the one standard, more detailed one. No need to go showing 50th, 95th, and 99th centile, systolic, diastolic, and mean arterial pressure. Okay. This is more fascinating by Bijovic, showing gestational versus birth weight. In the left is the one with the gestational age, in the right is the gestational age, almost showing almost matching variables, around 2 plus 2 minus 2 standard deviation. These are the causes we talked about. Renovascular is the most important one. Renal vein thrombosis presenting with hematuria, renal artery stenosis, about 20% of hypertension in infants, or compression from tumor, parenchyma, renal disease, congenital, autosomal recessive and autosomal dominant types, acquired acute tubular necrosis. So renovascular constitute for the most important. We talked about correction of the aorta. Endocrine causes, congenital adrenal hyperplasia. Hyperaldosteronism said to be, there is one recent study from Saudi Arabia showing the value of spironolactone for and used in bronchopulmonary dysplasia with transient hyperaldosteronism. We talked about this. This is more detailed. No need to go for it. Now, first-line investigations. We go more with the clinical sense. This is an arbitrary just a framework. Abdominal, just the questions to match what to do. We have to take 4 limbs pressure and review the history. These to show 1, 2, 3, 4, 5, the cuffs variable sizes in neonatal or in neonatal period. And this is how we should go with the standard that should cover for the circumference 80 to 40%, and for the from olecranon to acromion should cover about 40%. Electrolytes, urine analysis, renal and aortic ultrasound, chest radiograph, mandatory as first-line workup, plus, if suspicious, for echocardiogram and plasma renal activity, cortisol, vinyl mandelic acid, homovandellic acid, cranial ultrasound, renal radionucleotide, and renal angiography as clinical suspicion. Treatment, removal of iatrogenic, of course, make it of sense. Treatment of the underlying cause, cardiac or endocrine. Anti-hypertensive, when to be used and is it of use. Here, we can divide it to oral for the chronic, but for the urgency or hypertensive emergency, there is the infusion and the intermittent IV type. And this to show mostly for the spironolactone, as we said, most used with chronic pulmonary disease.
1 minute left.
Acute severe hypertension more than 99th. And to conclude, determinants are variable, neonatal in the first week, 3 major factors. Neonatal hypertension defined greater than 95th centile. Hypertension more frequently encountered in sick neonatal ICU, preterm babies. Treatment of neonatal hypertension is not evidence-based and most often driven by local practice and requires further research. There is no clear definition with no proper treatment guidelines. It needs a lot of research to build up guidelines to describe a standard manner. Etiology of neonatal hypertension should be sought before starting antihypertensive. Common etiology, neonatal renovascular disease, diagnostic approach, and ACE inhibitor first line of drugs and should be used after ruling out. Thank you very much.
Thank you very much, Dr. Adil, for this excellent review. And as we said previously, we will leave the discussion at the end of the session. So can you present?
Our next speaker, Dr. Saleh Al-Shurafa. Dr. Saleh is a senior consultant, pediatrician and pediatric nephrologist. He is the head of pediatric nephrology, Khatib Central Hospital, Saudi Arabia. He is the president of SHMS Society. He will speak about SHMS guidelines in children. In SHMS, we are very abroad. We are throwing lines about the hypertension in children, and you know, primary hypertension now is shifted back to the age of children as well. Dr. Saleh.
Thank you very much. I would like to thank the organizing committee and scientific committee for giving us this chance to talk about pediatrics. Actually, when we start in 2001, there was a question whether hypertension is present in pediatrics or not. And now, I was given the chance to talk about hypertension in children and adolescent Saudi guidelines. So there is a shift in the approach of Thank you. You see, and now, today, even we talk about neonatal hypertension. I don't know, Dr. Wesam, maybe later we'll talk about fetal hypertension, I don't know. Actually, hypertension in children is a growing epidemic, and unfortunately, high blood pressure is estimated to be prevalent in 4.5% in many studies. In our country, we don't have, a big, bold study, but we have a small, prevalence in small population. I'm going to show you. And a recent study in 2017, October, it shows that 75% of children failed to be diagnosed. So still we are so primitive. The clinical perspective on blood pressure has changed in recent years, and blood pressure measured regularly and improved knowledge and distribution of blood pressure values during growth. So I was asked to talk about our guideline, although we are just starting. So we formed a subcommittee. We were with adults together, forming the society. So subcommittee, charged with developing and updated evidence-based clinical practice guideline. So we provide recommendation on diagnosis, evaluation, and management of childhood hypertension. And the aim was for practicing clinician in outpatient and inpatient. So we will start, as usual, with definition. And I mean to put it because there is a big confusion in the terminology. We have polyterminology in different guidelines. In American, for example, they change from pre-hypertension to high normal, European elevated, and in ours still we are putting pre-hypertension. تعددت الأسماء والتشخيص واحد. So I'm going just to, go over it. The normal is below 90th percentile in all guidelines, and in recent Canadian guidelines, which has just appeared. In pre-hypertension, they call it high normal in US guidelines, elevated in European, and all the same definition between 90th to less than 95th percentile. European the same, Americans are the same. Stage 1 and 2, we are all the same, except that Americans, they change the word stage 1 to grade 1. So it all above 95th percentile, we call it hypertension. And stage 2, we are all the same, but we and European 99th plus 5. The American, they shift 99th plus 12 millimeter. So it is really complex. We have to have centiles, etc. Nobody can, memorize what is the specific blood pressure in that specific child, that specific height. And so blood pressure in children is a function of age and sex and height percentile. So what is normal for one child may be considered hypertensive in another child. Clinician usually cannot remember normal blood pressure for a wide range of children observed in their typical primary care setting. There are multiple, reference data, and the most famous is American and European. There are data for auscultatory and now data for oscillometric. But there is a weakness in all current definitions. It's built as statistical. It's not built on end target damage. This is a weakness, and most of the task force data is built on single blood pressure measurement. We see that our population is really different from other parts of the world. So Professor Abdullah Al-Salloum conducted excellent study. It's old in 2009, but it's really excellent, on 17,800 children nationwide. And his conclusion was blood pressure value in this study differed from those from other studies in developing countries and in the United States. This is how he compared, indicating that comparison across studies is difficult, and from that, every population should use their own normal standard to define, blood pressure definitions. After that, this is what appeared in Saudi Arabia. This is for Saudi children, and that's what we should use now. And you are seeing the left gears, the red, boys are blue, and as you all see, it's increasing with age. This is very simplified with age, and that's why we should use standard normograms. Primary care physicians, family physicians, pediatricians are very aware of how to use centiles, so it's easy for them. Or they can use table. So if we have, for example, 12-year-old child whose height is on 75th percentile and his blood pressure is 105 systolic, he would be considered normal. But if he is on 5th percentile, the same child, if his blood pressure value is 103, he is hypertensive. So that's why we have to go on tables and centiles to define the hypertension. And that's the major difference between pediatric hypertension and adult hypertension. For the sake of the time, I will skip some of the slides. Upon the Saudi centiles, we conduct a campaign to see how prevalent is the hypertension in our population. So we did the campaign. We studied 2,693 children, and we found 417 to be hypertensive, which is constitute of around 15%. And then we go for a second, and these same patients, we asked them, but only 253 children came, so 8% only. That reflects that one measurement is not really good. So we went ahead and do the third measurement, and only 6%. That 6%, whether we consider them hypertensive or not, I really don't know, because white coat hypertension, the kids are afraid from doctors, so we are not so sure that 6% of our population are hypertensive. If we take this value as other values in US and Europe, that is big alarm to our society. 6% of our kids are hypertensive. So we went ahead and did the ambulatory. I'm going to show you later on. So why this raise? We have epidemics of obesity. 15% of our kids are
you
obese.
have 10 minutes.
Huh?
10 minutes more.
10 minutes more. Not 10 hours?
No, 10 minutes.
10 minutes.
10,
Okay.
10 days.
Okay. Okay. And we have sedentary lifestyle. Epidemiological studies indicate 30% of obese kids are hypertensive. And I guess the hypertension, 6% are majority of them are obese. In next conference, I will show you the obesity, the weight versus height versus the blood pressure. It's a promise. In these cases, the same cases, I am following them. So hypertension and obesity are two common preventable disorders, and we need more studies. So fast food commonly contains unhealthy amount of sodium, and Saudi FDA now already put a rule that they have to reduce 30% of the salt, which I really congratulate them, and maybe that would affect the prevalence of hypertension in the kids. Evidence from epidemiological studies and experimental trials in animal and humans suggest that added sugars, particularly fructose, may increase blood pressure and blood pressure variability if you do ambulatory blood pressure monitoring. Increased prevalence of prematurity, survivors due to recent advances in prenatology lead to increase in prevalence of hypertension, unfortunately. So are we there? You know, as I told you, there is a lot of mess. We don't diagnose hypertension in children. And this is a study of 14,000 kids. 0.9 of them had a diagnosis of hypertension only, which is, you know, I don't know, this is screened in all United States. So when they go with the criteria, 3.6% of them are hypertensive. So only 1 out of 4 with hypertension were identified in the medical record as having hypertension, and I guess we are the same. This is different guidelines. So we shifted from the question whether we should include pediatric hypertension to include in our guidelines, and I think we might be one of the first societies that include pediatric hypertension since 2004. And now, like Canadians, only on October 2017, they publish their first guidelines. So we are in the front line, alhamdulillah. So we have different guidelines. You can take it, and there is chapter 26 for hypertension in pediatrics. Now, diagnosis, there is a shift in paradigm in how you diagnose hypertension. Is it based on just clinic visits or ambulatory blood pressure? In our proposed message in the guideline, instead of going to comprehensive investigation, we should go for ambulatory blood pressure monitoring to see whether they are really hypertensive or not, because it is very costly investigations in pediatrics looking for secondary hypertension. Unfortunately, yet, we don't have our own centiles, so we have to use centiles, and these centiles are almost similar to the height and weight of our kids. That's why I put it for you. So we went ahead in the screening in those 6% of kids, and we did ambulatory blood pressure. We finished it. Only 3% of them, they are hypertensive. So we have to be very careful not to over-treat and not to over-investigate. This is how ambulatory blood pressure monitoring in normal, green, and you see the reverse nocturnal hypertension suggestive of, secondary hypertension, or increased morning surge suggestive of, vasculitis process. So that will guide you how you investigate your kid. And this is how we classify hypertension based on 95th percentile as a cut-off point. So if they have below 95th percentile in clinic and ambulatory, this is normotension. If they are in the clinic hypertensive,
5 minutes left.
Don't worry, I will make it. I have a very clear message.
Thank you very much.
And I hope the message will be delivered clearly, because I think it's very important for our physicians practicing pediatrics. So white coat hypertension is, the clinic visit is high and the, ambulatory is normal. This is called white coat hypertension in adult and pediatrics. Masked, if they are, having normal clinic blood pressure but high ambulatory blood pressure, we call it masked hypertension, and that reflects on end organ damage. So we have to be very careful, especially for those having, chronic kidney disease, congenital heart diseases, etc. Sustained if both are high. And this is how we classify and how we treat the ambulatory blood pressure. So, and this is just sake of comparison between ambulatory blood pressure and the clinic blood pressure and home blood pressure monitoring, which I yet don't recommend home blood pressure devices, mainly because there are no cuff sizes and they are not validated for pediatric use, but we might use them in adolescent period like adults. I concentrated on definition. This is how it looks for one child. And the obesity, as you see all, the more obese is more prevalent hypertension. And how we evaluate if we diagnose hypertension. We have to determine underlying cause. We have to assess for comorbidities. So by going to patient and family history, physical exam, and laboratory imaging studies. I will skip laboratory, but these are from hypertensive kids visiting our clinic. End organ damage, whether it's present or not, to have it very evident, it needs long time to develop. But if you look for it, you will find it. So evaluation of organ damage is, commonly we look for left ventricular hypertrophy, and this is the most predominant. In our hypertensive kids, unfortunately, we have around 36% of our kids having left ventricular hypertrophy, which is really bad. So echo is a must. And this is one of the studies published in January 2017 indicating the same. This is how the effect, more systolic, more left ventricular hypertrophy, as you see in adults. And this is from one of the kids with, intimal thickness, which is very clear, very evident, and there is a correlation, very well correlated. So overall treatment goal is to achieve blood pressure level that reduce the risk of target organ damage, to reduce risk for hypertension-related cardiovascular disease in adulthood. And our aim is really to achieve optimal blood pressure, which is below 90th percentile. This is how we manage. Normal, we just encourage healthy lifestyle. Pre-hypertension, or whatever the name, you see it, we try to reduce the weight, and we recheck in 6 months, and we introduce physical activity and diet management. And in stage 1, we don't treat, we encourage healthy lifestyle, but if no control, by 6 months to 1 year, we have to go to medication. And in stage 2, we go for medication in the same time with a healthy lifestyle. This is one of the obese kids who gave me a headache, and he is the only child who did bariatric surgery because he is obese, to control his blood pressure, because the moment he reduces his weight, his blood pressure will go down, and if he increases weight, he will be hypertensive, and he had very severe left ventricular hypertrophy, so he had bariatric surgery, and now he is normotensive. Smoking is bad, especially in adolescent, and it's increasing, unfortunately, which cause a lot of blood pressure variability in ambulatory blood pressure monitoring. This is one of the obese who was just controlled by reducing the weight, and he had, you name it, a lot of investigations in different centers, and when he was referred to us, we just controlled his weight. He is normotensive now. So the target we should achieve is blood pressure is below 90 for age, sex, and height. In a chronic kidney disease, we do like you, we follow you in adults. We are your kids. So, but we take centiles, less than 75th centile in children without proteinuria, or less than 50th percentile if they have CKD with proteinuria. 24 hours ambulatory blood pressure is strongly recommended, and this is how we manage the ambulatory blood pressure. I will not go into details. The medications, you know, I have to be very careful. You see that small kid referred to me. You see how he's a lot of hair, and unfortunately, because they could not control his blood pressure by minoxidil, and when we control his healthy lifestyle, it was very easy to manage. You can use any of these. The dotted line, preferable not to combine these lines, continuous line, you can combine. I'm not going to go in detail for doses and how you manage, because you can find it in chapter 26, page 62 in our guideline. In conclusion, ladies and gentlemen, the detection and treatment of hypertension is important to prevent long-term cerebrovascular and cardiovascular complications. Aggressive attempt to identify and treat hypertension must be balanced carefully with the risk of overdiagnosis and overtreatment in these patients. In the last 30 years, non-invasive ambulatory blood pressure monitoring has emerged and has very valuable to our diagnosis. Clinicians should become familiar with ABBM to provide additional guidance, or you can refer it to center equipped with this. And compared with casual blood pressure measurement, ABBM has proved superior in predicting either target organ damage or morbid events. This is from our first course, whom we graduated the trainees for blood pressure measurement, and these are the ones who delivered workshops yesterday in this conference, and who conducted the organizing things and material, and I would like to thank them and congratulate them. They are the success of this symposium. I thank them very much. Thank you very much.
Thank you, Dr. Saleh, for this nice, comprehensive. I know this, the achievement of pediatric hypertension guideline was belong to you and your colleagues.
Our last lecture will be delivered by Dr. Badr Al-Mustafa, And Dr. Bader is a consultant family medicine, senior consultant family medicine and chronic care, clinical hypertension specialist in Khatib Primary Health Care, General Secretary of the Saudi Hypertension Society, and he's also the Middle East representative of the World Hypertension League.
If you make it lower, yes. If you make it lower.
Yeah. It's,
Bismillah ar-Rahman ar-Rahim. Shall I make it lower from here? Yes, please. Assalamu alaikum wa rahmatullahi wa barakatuh jami'an. It's my pleasure to be with you today. I've met most of you maybe yesterday. However, I may be talking about a child who is hypertensive. I may be talking about a mother who is having a high blood pressure. But now I'm talking about a father, a grandfather, which is almost a must. One of them is having high blood pressure. So this is not our patients. This is my father or grandfather, my mother or my grandmother. There is no, I guess, a home in Saudi Arabia is having no single hypertensive father or grandparent. So we need to give them some care. Unfortunately, once I'm retired, everybody is looking to me as if I'm just waiting for graveyard. Is there any chance to live more productively? We need to think of that. We know at least many of the examples who are very productive at the age of 70, 75. I know much more productive people at even an age reaching the 80. How to take care after them? Because we are neglecting them as a family, and we are maybe neglecting them as well as a service provider. I've been requested to be very short at the end of this morning session. However, this guy, he is almost 80 plus. He is functioning independently. Imagine that if he is losing his function, who will take care after him? However, he is having some problems in his heart, atrial fibrillation, some neurological problems, some lacunar infarctions. This doesn't mean that he cannot function. However, his blood pressure is slightly high. Shall we treat this or not? Shall we approach it? And if so, which medication I'm going to use? And I wonder, is there any evidence that these patients will really benefit from the intervention that I'll be giving to this patient or not? So I wonder if I can really cover all that in these 15 minutes. Let's try. We have still much more queries for high blood pressure treatment in an elderly. It's not only the high BP, but is it really hypertension? So what is the definition of hypertension in this age group? More or less, who is elderly? Is it the 65? Or is it the 75 plus? Or is it the 80 plus? Is it the biological elderly, biological age? Or is it the chronological age? Really, we need, all these are questions yet need to be answered. We know 50s who looks like 80s, but we know 70s and 80s who just look like 60s. So is it the chronological, or is it the functional or the biological? This has to be considered as well. There is one very vital issue in the hypertension management. This slide, by the way, concludes all my talk. And I've been requested to make it short. Maybe I'll just stick to 1 or 2 slides. I'll miss the other 30. So please be patient with me. Dr. Abdul Hamid Hassan, I guess this afternoon, will go to a very vital issue in blood pressure measurement, in blood pressure treatment and management, which is blood pressure measurement. Which blood pressure measurement device I have to use? If it is okay for everybody, definitely it is not okay for the kids. Definitely it is totally different for the elderly adults. So we have to make care of that. In addition to that, there is no one hypertensive elderly will present with high blood pressure only. We have multiple of comorbidities. So how to treat it? What medication I'm going to use? Is there a chance that there will be a secondary cause? Because we all know that high blood pressure in below 30, there is a chance to have a secondary cause for his high blood pressure. But almost it is the same if the patient is presented to me at age of 70 plus with high blood pressure. This high blood pressure may be a secondary to another organic problem that I have to pay attention to. We are not treating only high blood pressure, but we are having a geriatric syndrome. What is geriatric syndrome? I'm facing with many other problems, disabilities, comprehensions, understanding, take care of himself, Alzheimer's maybe disease, some urinary other problems that he's facing. All these I have to put in mind. So it is really difficult to have a specialized clinic in hypertension to treat hypertension. It needs a real generalized clinic that they are specialized in the geriatric people rather than to be specialized in hypertension. Is there any place for other preventive medications such like a statin or aspirin? Because the evidences for these medications are yet need to be waited for multiple of years to see that they are really effective. So what about the 70s? Shall I put them on a statin or aspirin? This has to be taken with a very crucial issue. This is an area we are missing a lot. How to monitor these patients? It's just only to measure blood pressure, how to measure it, how to make sure that he is reaching his target BB. If I really have defined it well, this has to be taken care of. I'll miss many of the slides for the purpose of time. However, we need to recall one fact that we may be knowing. What is that? If I've lived to 65, I have a big chance then to live to 10 more years. But if I've reached to even 80s, there is still more chance to have 7 more years to live. So if I'm facing a patient or a person who has already reached 65, then he is having in a good health, then there is a chance to live for more 20 years. And if I've met him at 75, there is still a chance for more than 10 years to live. And if it is at 80, there is still 5 to 7 years to live if he is healthy enough at that age. This means that I'm having really a chance to make the quality of life of the coming years better, not to leave it for comorbidities to come in. And just to flag up. Let's concentrate a little bit about how far they will benefit of treatment or not. Let's see a few of them. I'll make myself very selective in my, let's just put an eye on this. Many will argue about the blood pressure target that I need to go down with my patients. And you will see how far the cardiovascular complications will rise once I am 140 plus systolic. And if I am less, oh yes, if I am just below 70, that's great. I may be fine to reach, but once I'm going, if I'm just 75 or plus, there is a chance to have not the lower the better, but the lower will be the worse if I get below 130. So a very cautious approach has to be given to our elderly once they are around 70 years plus of age to go below 130. This is very crucial, I have to put in mind. We'll go just little about the quality of life in our patients. These are the 5 or 6 columns that we are usually following in geriatric patients. We are following in geriatric patients not only physical but as well mobility, self-care, doing the usual activities and so. Are they really different if the patient is having no disease, having hypertension only, or hypertension with comorbidities? And let's see that those who are having no hypertension, they are scoring much better than having hypertension alone or hypertension with comorbidities. So we need really much that our patient, if they are not hypertensive, to prevent hypertension. And if they are hypertensive, they do really benefit of decreasing the chance of having cardiovascular complications in terms of what? Not only blood pressure target, we are not targeting in treating geriatric patients blood pressure, please. We are targeting as well the whole health, which are these elements and which we need to keep it in our fathers, mothers, grandparents as well. Let's see, will really lifestyle changes, modifications affect the parent, the elderly parent? الكل بيقول كبير في السن راحت عليه، صغير ما عليه بتمرن وبروح وباجي ينفع. But will it really change our elderly patients? Let's see how far this will affect. Oh yes, we are having a lot of evidences. Salt restrictions, elderly are the most of benefit, are the most to benefit of salt restrictions in terms of blood pressure. So why not? So this is great for us rather than to use medications. What about doing exercise? Will our patients, elderly, will really benefit of exercise? Oh yes, you can see how far it may decrease. These are multiple of studies have been done which have been shown that we may decrease it by something around 5 to 10 millimeters of mercury by doing aerobic exercise. Why not to do it for the elderly? To take an overview in the last few minutes, we are facing high blood pressure. 70 of them, they are in the elderly age group. So we need to know not only the pediatric or the adult, we mainly need to know how to treat high blood pressure in the elderly age group. We are having one more issue. White coat effect is more. This means that really we cannot rely on the office-based blood pressure measurement in diagnosing, in labeling, and defining hypertension in our elderly. We need to have some other modalities. I hope Dr. Abdul Hamid Hassan will cover that in the afternoon. We are having a poor adherence to medication. Sabah al-Yom, Dr. Kurdi has mentioned a patient with multiple medications with just a poor adherence to medications. We all may be poor in pharmacokinetics. And we know that with polypharmacy, you cannot really just go like that. Not only with the, the overlap with other medications, but as well with other foods and so on. In addition to that, the patients are at increased risk of hypertension, of hypotension. Postural symptoms are a lot, much more, and this will make the patient prone to falls will make their life disaster. A fall, a femur fracture, pelvis fracture is a disaster for an elderly. We have to put a mind of that. We need to treat our patient, but not to treat the blood pressure levels. Really, I need to stop here maybe. Dr. Ghalib, how many minutes I'm having? Oh, great. Then I need to go beyond. This is an issue. The blood pressure measurement in elderly has to be done in multiple positions. We need to measure the blood pressure in sitting, and as well we need to measure the blood pressure in standing. This has to be done in the initial assessment of every high blood pressure patient at the initial setting, and to be repeated as well. If I'm going to increase my dosages or change my medications, and as well annually, because these patients are at increased risk of having autonomic dysfunction, which I have to put in mind. Maybe ambulatory or home blood pressure measurement is an alternative as well for the follow-up. So almost will be difficult really to rely on the office blood pressure in our management of our patients. I'll shift a bit in my talks to see the recommendations to which we are going to have my blood pressure or my patient's blood pressure to go through. So we'll go to, yes. When to start treatment? Recently, the Americans just go down to have the blood pressure has to be gone through. Once it is 130, in elderly, I need to treat. Really, in the SHMS, we are still sticking to that targeting or starting medications to be considered once blood pressure, systolic blood pressure is reaching 160. If it is less, we have to be very careful to start pharmacological medications. However, non-pharmacological approach is the place number one to be approached. In addition to that, the Europeans started to say something else, if it is 140. So we are in dilemma whether to go 130, 140, 160. I guess what we have done in SHMS is very reasonable. If the experts will go and just scan their patients, what are they doing in their clinics, it's a bit hard really to rely on an office blood pressure measurement, which is 140, to tell that, okay, I'm going to start my elderly patient on a pharmacological medications. Personally, I'll be very doubtful. Oh yes, if I'll follow the studies which have the American based their recommendation on, they based their recommendation on a sprint study mainly, which they use the unattended blood pressure measurement, which is not the way that we are dealing with our patients. It may be something else then. However, once I start treatment at 160, what target I need to approach? The Americans, they have told I need to go to less than 130. The Europeans to less than 140, even to around 130, but try not to go much beyond that. And you know why? I have shown to you just a few minutes ago how the curve was going down. But they put something else here, F, tolerated. The Saudi hypertension guidelines aiming to less than 150. We may go to less than 140 if it is that the patient is fit enough and he is tolerating the lower levels. So we have to be very careful in that. Which medications I'm going? It's maybe no different other than that we have to put some care not to start beta blockers in this age group unless the patient is having some other indication for that. The most important is not that, but to start very slowly and to titrate slowly, not to titrate every 2 weeks or so. We need to give chance for 4 to 6 weeks to titrate our medications. And once I'm titrating, I need not to measure just the blood pressure, but I need to measure the blood pressure in standing and to make care that I'm not really having postural symptoms.
1 minute left.
Hopefully to finish in that, inshallah. أبوي أمي رحمهم الله يمكن يبغى يروحوا الحج، وفي ذاك الوقت لربما الكل يقول ليش تبغى تروح؟ If my father or mother likes to have a wish at the end, near the end of their life, I need to pay a lot to do it. So how come me as a physician will really respond to that request? I need to go to check, to check many things. And one of them, I have to go for a good review within 2 months, not just 1 week or 2 weeks before. I'd like really to make him fit as possible. And this cannot really happen unless I have enough time to have it. We have to discuss with the families all these issues. He needs a care provider to go with him. And he must know what to do if anything wrong has happened. All these instructions must be handled and written. I'll hold here. I hope our patient Mahdi, we can handle him better with a little better of understanding. I know that the subject is very crucial. Just one last statement. Thanks a lot for all of you who have gone and done the evaluation. We have received almost 30. I hope that everybody in the afternoon will go and insert their evaluation. This conference, this event is for all of us, and it is our own opinions that will make it better in the future. Thank you.
Thank you very much, Dr. Badr. That was very good and excellent review of the subject. And I'd like to call our eminent speakers now to have a few minutes before lunch for discussion. If any of the audience has a comment on discussion, please go ahead.
I'm encouraging the audience to just ask questions rather than the senior colleagues. So don't hesitate to ask any simple, even a primitive question. Feel free the audience to ask, to speak in Arabic or English. So we need interaction.
Hello.
Test one.
نسمعك دكتور وليد، تفضل.
Microphone is not open. Can you open the microphone?
Hello. Yeah, it's okay. Thank you.
Thank you very much. I mean, Doctora, do you advise that patients who are pregnant and hypertensive to be managed for the hypertension by OBGYN doctor or by hypertensive, internal medicine or whatever doctor. I mean, this is number one. Number two, women will say lactation and medication for hypertensive patients. For how long we can choose, or we should choose the medication to not to have any problem with the infant or with the baby, because lactation, it might be 3 months, 6 months, or 2 years. Thank you.
Hello, can you hear me? Okay, so this is a very good question, and I was, happy that we heard some of that at the beginning. So, do we treat them ourselves, or we send them to the experts? We are not really the experts in hypertension. So it really depends on what case are you dealing with. If you are dealing with somebody, Hassan and I, we work on many patients together. If you have somebody that is like really high risk with, renal failure, with a post-renal transplant, well, even, like type 1 diabetic with like a lot of comorbidities, then definitely it has to be a multidisciplinary. We cannot deal with these patients on our own. We have to consult you guys. If we are just dealing with preeclampsia, then usually we do not consult, the nephrologist or the internal medicine unless we have difficulty controlling the blood pressure. So I think this is usually what most of the obstetricians will do. With regards to the breastfeeding, it really depends, doctor. How, bad the hypertension is, if there's comorbidities, how important it is for her, for example, that it's essential to be on like ACE inhibitors, and because of breastfeeding she cannot do that, then you just have to weigh risks and benefits and then decide what's the best. Obviously, her health is more important than the breastfeeding. We are very much breastfeeding, supporters, and we know how the importance of breastfeeding, but that cannot be on the extent of the mother's, life or morbidity for sure.
Dr. Wesam, but I'd like to comment on that many patients with the preeclampsia do have an underlying renal disease. And
Sure.
as you know, in preeclampsia, you have endothelial dysfunction, and that might be the reason. And many patients with renal disease sometimes do not show, or their symptoms would not appear until they get pregnant.
Sure.
So I would be inclined to say that many patients with preeclampsia need to be actually evaluated by nephrology and follow up afterwards, because many of them probably would have an underlying renal disease that has appeared during that
I
time.
fully agree, and it was on one of my slides actually, that patients who have severe, especially early onset preeclampsia, will need to be evaluated for underlying secondary cause. Definitely, I fully agree.
Yes. Hello? Yeah, thank you. My first question... Yes, it's working now. It's working.
Yes?
Yeah. You mentioned about how tight you can be in blood pressure reduction and the cost effectiveness. Do you have any data to support that? Because, in GDM, we have certain guidelines which goes with lower to have a better outcome in terms of pregnancy and for the fetus. Do you have similar data to support that the cost effectiveness outweighs the benefit in terms of hypertension? That's one question. The second is about the use of aspirin. We know that it can increase the fetal hemorrhage and the maternal maybe hemorrhage. So what dose you recommend and at what stage of pregnancy? So that's for the pregnancy and hypertension. I have another question for the elderly also. If you don't mind. Yeah.
This?
For For the cost effectiveness, this is actually what I presented is a big, big study on the cost effectiveness. And that study has shown that if you are less tight versus more tight, if you are less tight, then maybe you're not going to use a lot of medications to start with, but then you'll have more likely to have severe hypertension. So you're going to use more expensive maybe medications later on. So there's really no cost benefit from being less tight. Okay? And the
with
effects
regard
on
to
the
the
fetus,
outcome, fetal
yeah,
outcome.
and the fetal outcome is actually not different. In that particular study, which is a big study, thousands of patients, there was no difference in the outcome. Because again, I mean, it's less tight versus more tight, and then you are having more severe hypertension that might necessitate more intervention or more early delivery. So at the end of the day, there is no difference in the outcome. For the aspirin, there's really like, you know, tens and hundreds maybe of studies of aspirin use in pregnancy. I mean, really, we don't get bleeding, we don't get like negative effects on the fetus from using aspirin. What is the dose? There's a lot of studies that tell you that dose is less than 81, which is, I mean, the 75 which we have. There's a lot of people who are non-responders to that dose. So it's not recommended anymore to give a dose less than 81. Okay? So the normal dose is 81 to 100. In very high-risk patients, and this is, again, this is like in recent data, in very high-risk patients, it's actually even advised to go to doses as high as 150 milligrams daily. But really, really high-risk patients for preeclampsia. So normally, use 81 to 100 in really high-risk patients with the consultations, maybe with, you know, with whoever, like internal medicine, nephrologist, and maternal fetal subspecialist, 150 might be the dose.
With regard to the elderly, I mean, use of thiazide, we know that most of these elderly patients have hypovolemia, and use of diuretics in general and thiazide specifically might result in loss of a lot of good minerals in the urine, so it will cause hypomagnesemia, hypocalcemia. I mean, so I think the selection of or the choice of medication in elderly has to be taken into consideration with the rest of the, like, you know, bone issues and other issues. So, I mean, is there any specific study that support this similar to the younger age group, comparison to younger age group?
Shukran. Thanks a lot for your questions. The issue really is the vulnerability to have some of these side effects is very high in this age group, which put us in more burden really to have much more frequent tests and reconsideration of changing their medications and or even their dosages or even timings, rather than really to have a specific choice that it is apart from the general hypertension patient approach.
I'd like to comment on that about the use of diuretics in the elderly, that elderly females are more prone to get hyponatremia due to thiazide. And even if the dose is 12.5, and it can arise about 6 months or 1 year after treatment, and may last few weeks after you have stopped the treatment because the effect in the tubular cells lasts for a few weeks. So I think it's better to avoid diuretics in the elderly females because the chance of hyponatremia is much more than any other patients.
Yes, to an extent that may be okay. However, but we are faced in practice with many issues that both thiazides and low dosage, one of the alternatives to be given, especially if we are talking about systolic high blood pressures in a fit patient with a good renal profile, then still diuretic will be a choice with low dose of chlorthalidone, for example, or thiazide-like diuretics.
Yes, Dr. Dr. Badr, thank you very much for all colleagues and for you. My question is, how would you approach an elderly patient with blood pressure 180/55? When you sacrifice the systolic because of the diastolic to protect further drop in diastolic. So 180/55, would you treat or you hold?
Over 155.
180 systolic over 55, which is not unusual. We are
This
facing
is not
such
unusual at all.
Yeah.
We do face it almost daily in our daily practice. We need really to verify the blood pressure measurement a lot for these patients. And we need to verify, in addition to that, their symptom profile. Let me recall many of my patients. If you just have a symptom profile just early from their wake up till midnight or till their sleep time, they may have presented with symptoms like postural symptoms or even symptoms of queerful silent ischemic symptoms, which we have to be careful then to start any medications to lower blood pressure. This is one issue we have to put it in mind. The other issue, these patients need out-of-office blood pressure to be taken in terms that white coat has to be excluded very carefully. And we know all that with white coat we have more systolic reaction rather than diastolic. But I'll be very cautious to go with these patients to start with. And at the end, if the comorbidity profile and the target organ damage profile really helped me in starting and encouraged me to start the medications, I'll be started in very low dose, and I'll see the patients maybe weekly to adjust his dosages and timing. But we have to be very careful in that example. Yes, please.
Thank you very much, everybody. At the end of this session, we like to present the certificates to our speaker, and we start with Dr. Wesam Kurdi. Dr. Adil Sinan, thank you very much. Dr. Badr. Dr. Badr. Nice lecture, we like it. Dr. Saleh. هلا نشكر الدكتور صالح الحقيقة على جهوده في السوسايتي في هذا المؤتمر. الله يحفظه. تفضل دكتور صالح. الدكتور غالب تفضل.
وطبعا ما ننسى بروفيسور سعد الزميل العزيز. يعني he made it in very short notice. I really thank you very much.
Thank you very much. Please, dinner, lunch and prayer. Please, we would like to start 1:30 sharp because we are half an hour late for the schedule. So please make it 1:30 to start, inshallah, after lunch. Thank you. جزاكم الله خير.
ممكن صورة جماعية إذا ممكن. أبو تميم، دكتور عادل، حسام، عبد الحميد، صورة جماعية إذا سمحتوا. إذا سمحتوا صورة جماعية بس. ليديز اللي معانا إذا حبيتوا تجوا لو سمحتوا صورة جماعية في الوسط.